very much. Representative Christiana.
Thank you, Mr. Chairman. And Mr. Trembulak, thank you very much for coming here and for your testimony. I think one of the previous questions asked if you had a contract with Highmark. You answered you did. Do you also have contracts with the commercial insurers like Aetna,
Yes.
United, Cigna?
All major payers.
So, I mean, if you could quantify the percentage of insured individuals in your area, could you try to quantify what percentage of them have access to your facilities?
Well, I'd say of the patients that we see in our organization, 30% of those are probably insured by our own health plan. Approximately, the other 70% are insured by other insurers. Now, there's some self-pay, but it's very small these days, and then there's charity care. So approximately 70% are other insurers.
But what I'm saying is there's rarely the case do you have someone that has insurance that is locked out from being in network, right? So my question is, while you say this will have a chilling effect and could hinder Geisinger, my question is, if you already have contracts with all of them, your service territory has complete access to your facilities, how I guess, can you justify to me how in the world this bill would affect you at all?
Because what we're trying to do is to change the methodology and approach to contracting. So rather than contracting for units of service, which is what most of those contracts are, the more work we do, the more we get paid. And then we argue every year what's the level of payment for each level of service we provide. It's really counterproductive. This would carry out or perpetuate that historical approach. What we'd like to do is to change the whole approach to contracting, really going into more bundled payments and payment for outcomes of work that add value, and that it was referenced in earlier testimony. So how do we really focus contracting around the value of healthcare versus just paying for services of work? We're one of the few businesses, if we screw up and we do rework, we get paid again. That shouldn't occur. If there's a unfortunate error or problem, we should fix that at no cost. And that kind of whole approach to changing how contracting is done between providers and payers is really key. And part of the continuums I referenced, again, it's very important for payers to integrate with providers, whether they're, I'll say, owned by the same umbrella or separate. They need to work together to really change methodology.
One final question. Do your insurance clients have in-network access to your competitors? Mm-hmm. So your Geisinger Healthcare plan contracts with your competitors in this region. And excuse me, I'm from Western PA, so I don't necessarily know who your competitors are.
Well, in our market, we have few competitors, but CHS, Community Health Services, has acquired many of the hospitals. We contract with CHS.
I think it's important to note for the members that while we maybe disagree on how to get to a model similar to yours, I got to commend you for contracting with your competitors as well as contracting with all the national insurers and competition. If there's a way to strengthen the bill to make it better, I think Representative Frankel and I have been very clear on that. But I have to commend you on your approach and your fairness to your constituents. Thank you.
Thank you.
Representative